So let's try an AP view. Well, look at this. You can see the sacrum and the pubic symphysis here. It looks pretty good. These are the sacral nerve roots. This is probably the fifth sacral nerve root. If you can see this little opening here, this is probably the caudal hiatus. If we were doing a caudal epidural injection, we would enter here. We'll look at that again on the lateral. This is the coccyx. The coccyx doesn't seem to have the usual extension. Normally we'd see 5 segments that are fused. As we see up here, we can see the traces of the sacroiliac joint. Now we're going to move up ever so slightly. And let's have a picture looking up a little bit more. And this is nice. We can see the full sacrum here. And to be fair, if we had a patient where this was actually showing this kind of anatomy, it's wonderful. Patients have such variations in anatomy. However, the most important parts are easily seen. We can see the posterior spinous processes back in the sacrum. We can see what I would surmise is S1, 2, 3, 4, and 5 would really be way down here, but often you don't see S5, or certainly you don't need to treat that. And here I can see the interspace of the L5 and the S1. The S1 is up here, but it's fused. The 5 sacral units are fused. Let's move up again, please. Now here I'm seeing a good section of the lumbar spine, L5, 4, 3, and 2. And you can see we have the nice transverse processes that are shown. We have the posterior spinous processes. I can see the superior articular process and the inferior articular process, which form the zygapophyseal joint, which allows the back to move. It's also called the facet joint. And this is actually looking quite nice. Let's go up a little higher. Okay. Let's go back down. I want to put a marker for the L5. Let's go down a little bit more. Okay, that's good. So let's count. This is 5, 4, 3, 2. Let's put a clamp. 5, 4, 3, 2. So that's on 2. Now let's move forward a little bit. So this will be L5. I'm sorry, this will be L1. Okay, that's L1. Now, normally we would see ribs extending down here. This is T12, so we would see the T12 rib, but we don't see that on here, which is one of the variations that we have, obviously, from a cadaver model. Let's go up a little higher. Okay, and now here's where we do have the ribs. We can, if we were practicing a T12L1 block, we would just assume that this area that I'm marking up here, we could always pretend that this was the T12 and that we were going to do a delicate injection there. Okay, let's move up a little bit more. So here we can see more ribs, and the reason I wanted the ribs here is because in case I want to do articular joint blocks along the ribs, this is nice to have. Let's move up higher. And a nice touch, as you can see, the spinous processes, like the thoracic spine, are angled sharply downwards. In the lumbar spine, they're more straight. In the thoracic spine, as we go up, they start angling down. In the cervical spine, they start coming back out a little bit. Let's have a look at the neck, all the way up. Well, the neck looks wonderful. Let's head down just a little bit. I think I see something that looks like maybe the first rib. Okay, so we'll, normally the first rib is quite thick. It's the thickest and broadest of all of the ribs, and it's very small. It's very difficult to fracture that rib. In fact, in the emergency room, if you see a fracture of that rib, you automatically admit the patient to rule out any major vascular damage. So we would, if we were taking this as T12, so we could say C7, 6, 5, 4, 3, 2, and 1 will be up there. But this is really enough for us to do most of our cervical procedures. Just out of curiosity, let's head a little bit higher. That's nice. We actually are seeing some dentition. We can even do high C1, C2 nerve blocks. And certainly in my field of practice, I don't need to do any dental work. But it's interesting and it's nice to see, because this is what you do see in the actual patient. Down. We'll do the same thing looking at lateral views. So if I was to get a lateral view, too high. Let's see. Can you shoot a picture from there? We need to raise your C-arm. I'll keep going. Higher. A little higher. That's it. Let's have a picture there. Okay. Let's get a nice clean image. If you can see here, this is the sacrum, and that is where the tip of the coccyx would be. So here is, if I was doing a caudal injection, I can see my needle could enter in this area. And again, the distal portion of the coccyx is removed, probably because of manufacturing. They didn't want that to break off. Let's go up a little higher. Let's see what else we have. I think we have to come back down a little bit. Come down a little bit more. So here we're seeing the sacrum on a lateral view, 5, 4, 3, and you can see this is where the disc would be sitting. This is the foraminal opening here, and here we have the nice posterior spinous processes and the articulating process of the facets. Now the lateral view is of course important for many of these blocks because we want to see our depth. For most procedures, we want to stay out of this area and confine our procedures to really from this line and back, unless we're doing work for the disc. Okay, we have to drop the C-arm down just a little bit. Let's go back a little. Okay. So this is, anatomically you wouldn't see such a large gap. You would surmise if there's a disc up there. And this is a fairly nice lateral view. You can see, well, this is where the disc would be sitting right in here. This is the body, posterior spinous process, and if we were doing medial branch blocks, we would want our needle tip on a lateral view to sit or hug somewhere in this area. So anatomically, this looks really, really quite good. Let's face it, the purpose of the Phantom is to get our basic raw skills on doing injections in the neck, thoracic, lumbar, or the caudal space. And I think this Phantom is going to be more than adequate for teaching for that purpose.